What settings should I apply to Medmont Studio to make the best use of it for ortho-k fitting? The newer versions of software, thankfully, have really set up their screens for optimal analysis, both baseline and the subtractive map. But there might be a few things that you can do. You might look up under YouTube Medmont defaults, setting up your Medmont Studio software, something along those lines. And there's a number of them both for version 6 and version 7. So those will help to give you some idea of how you want to manipulate your software, both from the default, but also in other directions as well. And maybe we'll just go through a quick example. Okay, here's an example of baseline topography. I'm sure you're familiar with the attribute side of the window. Make sure that you have your sag differential at 8 millimeters listed. It should be visible on your attribute window. And this tells you when you need a toric or symmetric landing ortho-k lens or toric or symmetric landing corneal GP. When your sagittal differential is 30 microns or greater, that's when typically the peripheral cornea is toric enough that we may not have the optimal alignment with a symmetric landing lens. In this case, this patient has 19 microns of sag differential, so meaning whatever the horizontal meridian is, or the flat meridian in this case, the steep meridian is 19 microns deeper. So you might have 19 microns of fluid underneath 12 and 6 o'clock in this with the rule case. Once it gets upwards of around 30, that's when you start to see the lens more destabilize more, that it may decenter, it may be moving a little more, may not be as comfortable. And then from an effect perspective, we may not have the lens centering as well as we would like it to, and the effect as optimal as we'd like the epithelium to respond. So using the axial and the tangential map are two of the ways that you might analyze your baseline topography. Certainly to understand, is it apical or limbus to limbus astigmatism? Will it be an easy case, or limbus to limbus a little more challenging to push out the sill? So this really, the sagittal differential is the principal one that I would make sure is up on your main window. One final thing on this map is when you're doing your baseline analysis, and really any topography screening, make sure you have your normalized power, normalized scale selected. And the reason for that is it will go from the flattest it can read at the bottom of the scale to the steepest it can analyze at the top of the scale, and it gives you the most definition. If the scale is set absolute and it's maybe a 20 diopter scale, but your eye is only 4 diopters of power, you're not going to see a lot of definition. Conversely, if the eye is beyond the scale, you're really going to be missing information. So by setting the eye to a normalized scale, then you get a little more detail on the contours. And this is a helpful way to be able to say, is it apical, or is it limbus to limbus astigmatism? Is it a good or bad candidate? That kind of thing. Now going to the subtractive map, when we select our baseline, then our post-wear topography, we want to do the subtractive analysis. So that's under View and Compare. If you right-click, you can add to the quick access toolbar. The way you've seen, I've added a number of icons up here that I use most frequently, a number of analyses that you're going to click on the most. So rather than clicking on the pull-down menu to grab a specific function, you're able to right-click on that specific attribute or that specific analysis, and then it adds it to your toolbar up at the top, making you a little more efficient. So I'm going to select the subtractive analysis, the comparison function, and then that will bring up our subtractive map. Now, this is one where, as far as setting up your defaults, they're pretty much done already here. You can see that Medmont has 2 diopter, 3, 4, 5, 6 diopter scale, as well as a really extreme 10 diopter scale. Now, being able to manipulate these has some value in that here, if you look at your effect, we have a 4.14 diopter RX change, a 4.14 diopter ortho-k effect. Now, looking at the scale, you'll notice that we're really missing data in here. We're missing what's happening in the center of this topography. So by using a plus or minus 2 diopter scale, you see -2 up to +2, we have a scale this tight, but this patient had a 4 diopter flattening. We're really missing what's happening here in the center. So clicking on the scale here allows us to move it up to that 4 diopter effect. In fact, I would go to the next higher so you can see if there's any high points that you might be missing or any areas that you might have even more effect than what's happening apically. And that's visible here just to the temporal side of center. We're getting slightly more effect than 4.14. We're getting almost 5 diopters, 4.7 diopters of effect. So this is a helpful tool. It should be in all of your newer versions of Medmont where these scales automatically exist and you're just going to switch on each patient between them. Now you might default to the 2 diopter scale. That'll give you lots of pop of that big blue treatment area. But if you want more detail, you might alter it to one of those higher scales. And the same thing is true when you're doing your tangential analysis